Hi, good morning, everybody. My name is John Schreiber. I'm the CEO of NJPAC, and I welcome you to our Business Partners Roundtable, and that's the Art Center's series of online conversations with business executives, thought leaders, and elected officials from New Jersey and well beyond. In the past, you remember those days, pre-pandemic, NJPAC held these events in the Chase Room on our campus in Newark. For the past year, we've been happy to share these discussions on topics that concern all of us virtually. I want to thank our Business Partners Committee Chair, Joel Sherman of Atlantic Tomorrow's office, for his invaluable help in planning and executing these events. And I thank all of our friends at PNC Bank for sponsoring the Business Partners series. Today, we are really pleased to be joined by two guests from RWJBarnabas Health, the president and CEO, Barry Ostrowski, and Deanna Vincent, who is the senior vice president, chief social integration and health equity strategist. Barry leads RWJBarnabas, a comprehensive academic health system that includes 11 acute care hospitals, 3 children's hospitals, a pediatric rehabilitation hospital, and a freestanding behavioral health center. The system's private-public partnership with Rutgers University includes the Rutgers Cancer Institute of New Jersey, Rutgers Health, and Rutgers' education, research, and clinical activities. Altogether, the system includes more than 2,500 practitioners, making it one of the largest medical groups in the country. In addition to his enormous responsibilities at RWJBarnabas, we are grateful that Barry serves as the co-chair of NJPAC's board of directors. Deanna Vincent is, in her current role, responsible for leading the RWJBarnabas program that both she and Barry will be discussing with us this morning, Ending Racism Together, a system-wide anti-racist strategy designed to ensure all RWJBarnabas Health patients and employees are afforded an equitable environment that is free from discriminatory practices. In addition to promoting equity at Barnabas itself, Deanna also works with internal and external stakeholders to promote anti-racist policies and invest in the communities that the system serves to promote equitable health outcomes. Just as a reminder of our timing this morning, this is a 45-minute session, 30 minutes or so of Q&A with Barry, Deanna, and me, followed by 15 minutes of questions from you. So if you'd like to ask our panelists a question, you can do so at any time by typing it into the Q&A box. You can find that Q&A box when you hover your cursor at the bottom of your Zoom screen. I am now fully expressed, and I'm delighted to say good morning to Barry and Deanna, and thank you for being with us.
Morning, John. Thank you for having us.
Pleased you're here. So let me start with a very simple opening gambit. Why is it important for a healthcare system, especially the largest healthcare system in New Jersey, to launch a program to end racism?
Thank you, John. And by the way, not only thank you for hosting us, but thank you for making this topic as visible as it needs to be, quite candidly. And as you suggest, as a healthcare system, I think it all boils down to the mission of our organization, which isn't terribly poetic, but I think it is direct. It is our mission as an organization to improve the lives of people who live in the communities we serve. Now, we do that through conventional clinical programs, outstanding doctors, nurses, technologists, and wonderful programs that surround those professionals. But 5 years ago, we launched a program to address the social determinants that exist in our communities, recognizing that if people lived in substandard housing or were chronically unemployed or didn't have access to nutritious foods, they were going to be sick and they were going to suffer beyond that which our clinicians could actually address in a timely fashion. As you look at what happens in our communities, you immediately are struck by the fact that there is structural racism within our culture, and people suffer in our communities as a result of racism. So for us to ignore the existence of racism, which of course has become dramatically obvious over the last year, it's been here for 400 years, but it's become more obvious recently. There was no way we could ignore the need to be a proactive dynamic in addressing racism. And while it is a difficult conversation, it is a difficult journey, we're in the business of difficult conversations. We have to have difficult conversations with patients and families. And so we couldn't shrink from the responsibility of launching a program designed to be anti-racist. As you know, most people say, I'm not a racist. For us, that's not enough. It's not enough not to be a racist. You have to proactively be an anti-racist so that we tear down the racism that exists in our communities, which in our case will enable us, we think, to better perform towards our mission of improving the lives of the people in our community.
Deanna, do you have a take on that first question?
Definitely. And as Barry said, for years, we've been fighting the ramifications of racism, diabetes, heart disease, but now we need to get to the root causes if we're going to eliminate the health disparities and seek to achieve health equity. We know that 80% of all health outcomes are as a result of social determinants, and racism is a social determinant. Even if you look at really the that our life expectancy is, our zip code is a predictor of our life expectancy. And if we look at Newark, so we look at Beth Israel, their zip code life expectancy is 68 compared to 82 in Livingston. Mm-hmm. Conversely, if you look at Trenton, where I'm from, life expectancy is 70 compared to Princeton, where it's 84. And we know that those populations look different, primarily mm-hmm. Black compared to primarily white. Mm-hmm. So we get to addressing racism so that we can achieve health equity. And for too long, we've been addressing the symptoms and other things, and we need to really address the root.
Deanna, define anti-racism.
Anti-racism is not just being kind and being nice, but it's educating ourselves on being proactive, not being an ally, not knowing what a microaggression is, looking at processes, procedures, and behaviors. So no longer accepting policies that are racist. Mm-hmm. So really dissecting these things and therefore creating better policies. So for instance, taking a scalpel to things as opposed to just accepting them as they were, which is what we've done for so long in this country. And I think we need to do things differently.
Agreed.
So being proactive.
Right, being intentional. So how and when did this endeavor, this really seemingly unique endeavor, Ending Racism Together, how did this initiative come about?
Well, maybe I'll start, John. So of course, last summer, the George Floyd murder raised, I think, everyone's visibility and attention focus on the existence of racism. And I'm embarrassed to say, as an individual, as I watched it in horror, as others did, I didn't immediately have the sensitivity of how it affected my Black colleagues within the organization, throughout the organization. And as I started to inquire, which I probably should have done years ago, I found that the impact was not only palpable, but almost paralyzing. And so thanks to Deanna and a number of other colleagues, we gathered to talk about how it is that things of this nature affect you if you're Black, and how it penetrates your life professionally, socially, et cetera. And at that first meeting, we literally had testimony by Black colleagues of ours about what it means to have to go through life facing the very challenges, policies, and limitations that Deanna referred to earlier. And it was at that moment that we sat down. Deanna said, you know, it's great to talk about it because we were fond of doing that kind of stuff. What are we going to do about it? And it is, of course, a difficult conversation to have. But I am blessed as a leader to have an incredible board of trustees. And we went to the board and said, we want to start this journey. It's going to be provocative. It's likely to incur a serious amount of pushback, either in or outside the organization. So it'll be anything but smooth. We're not doing it for headlines. We're doing it because we need to change a culture. And that was the start. And so we put together a management group, and Mark Burson, our board chair, put together a board committee to oversee this. And we've been at it since then. And like many things, when you start on the proposition that this is a problem that we can fix, and then you find out the depth of the problem, and how long it's going to take and how much perseverance is going to have to be applied, it is a sobering experience to even undertake it. But I have to tell you, I couldn't be happier that we've undertaken it. I'm not terribly pleased with some of the things we're finding, but clearly undertaking it has been a wonderful event for us in our organization.
Deanna, what were some of the challenges that you encountered as you and Barry and other leaders developed this initiative?
I think, as Barry said, you know, we knew we would find people who may not agree, and just hearing people
who may not agree that there's a problem, who may not agree that there's something that needs addressing.
That there's a problem, that we as an organization should be the ones to fix it, that we should be moving forward. I think also we are in New Jersey, that the fourth most diverse state in the nation, and people come with their own ideas and their own baggage. We all do. So as we begin to embark on this journey, those of us who are really passionate, we want to boil the ocean all at once. And also, how do we pare back? What things can we tackle now? What things sadly have to be not put on the back, we kind of put on the back burner. What can we prioritize? So really that prioritization, and really understanding where we can affect change. So that was challenge number one. How do we have these conversations? So we have embarked on many conversations about race that was previously taboo. You don't talk about race, religion, any of that in the workplace. Mm-hmm. And how do we do it respectfully, even for people who have differing opinions, because that matters. We want to understand everyone's opinion, even people who don't believe that there's such a thing as systemic racism, because that adds to the conversation. It adds to the type of mandatory training that we're going to have across the organization. It adds to what kind of policies and procedures we're going to put in place, because that is going to be the future of the organization, and everyone's opinions matter, because that has led us to the place that we're in right now. So we are still uncovering the challenges, and I think other challenges are in how do we move forward, and how do we move forward together or maybe not together, because I think there may be people that this might not be where they see their future, and that's hard as well.
Mhm. Yeah.
John, if I may, just to elaborate on the response that Deanna's given, which is directly what we faced. To her point about actually having people who didn't think there was a problem. Now, it sounds in the context of what we're dealing with incredible. Deanna collected data. We are a data-driven business to a certain extent. You get diagnosed, the scientific approach is taken, and it's all about data and readings and the like. So Deanna and her team put together data to show everyone how it actually happens in our organization that there is racism. And the data almost speaks for itself. And for those who thought there was no problem, they now face certain data. And I'll share with you something that, at least generically, is true, and I would think it could be true in many business organizations. We, like others, have progressive discipline for people who unfortunately break rules. And it's going to happen. We have tens of thousands of employees in our organization. And if you look at the quantity of progressive disciplinary actions taken with our employees, the disproportionate number are of people of color and particularly Black. Now, so you look at how could that be that that's the case, and you begin to uncover a certain level of subliminal, unconscious, microaggression racism, and it's there. And when we had that data presented to our colleagues, it was an aha moment. It was a moment in time when people, typically when you get data like that, you reject it. Can't be right. Got to be wrong in some form or fashion. But this data was so overwhelmingly persuasive and accurate, of course, that I think it began to set the premise for not only is there a problem, but this problem happens every day. And so we've got to do something to stop it. And I think the challenge of convincing those who think that there's not a problem was really met by the data that Deanna and her team put together to start to educate all of us about what life is like in real time in an enormous organization that never closes. We have this problem.
Mm-hmm. And just to estimate, of 100% of Barnabas team members, was it a minority of colleagues who did not see an issue that needed addressing, or what?
I would say it's a minority. It's too big a minority.
Right.
And so, like on many issues, you have people who are committed to correction. You have people that acknowledge a problem but are more ambivalent towards the steps that have to be taken to correct it. And then you do have people who effectively say, I don't believe there's a problem, or it's not my job to fix the problem.
Right.
So that stratification, I don't think is unusual, but in this particular case, it is a challenge.
So both for each of you, talk about how racism is manifested in a healthcare setting. What are some of the issues that people of color might encounter at a doctor's office or at a hospital that their white counterparts would not?
So many ways. Let's start with, and this is nationally as well as in our facilities, probably, longer wait times in the emergency departments. Lack of race, cultural, and ethnic concordance with providers. And we know that when there is concordance, so patient, provider having the same race and ethnicity, we know that they're more apt to go for preventive care. They're more apt to share, and they have better outcomes. And that also goes to language provision, making sure that they have translation and interpretation. And while that's mandated by statute that they receive it, it doesn't always happen in a timely way, and people are embarrassed because they believe it makes them look stupid. So a lot of times they have to bring a child, or they call in someone who may speak the language. And I wouldn't want to provide sensitive information through a third party, or not to my 10-year-old son about sensitive issues. So then you don't. Also, not giving the same level of pain medication to African Americans because we have higher pain threshold, or we're drug seeking. I remember my husband and I had just gotten married. We were young once upon a time, and I had an asthma attack. And I'm from Trenton, and it was middle of the night, and we were in jeans. And the first thing the emergency room nurse said to me was, "So do you have any clean veins?" And I don't drink. I don't
Wow.
do anything. And at the time I was working in maternal child health, and I was able to march up to the CEO, and of course the nurse received training, and I'm sure some other things, but I shouldn't have had to do that. And the data has also shown in our hospitals that in our predominantly more diverse hospitals, we do give out less pain meds than our primarily white hospitals. So that's something that we need to look at. So I think the other things that we see are artificial intelligence, which in some studies, people of color have lower risk scores, so therefore they are not referred to specialists when they have the same problems as their white counterparts. Now, AI can also take away bias, but it has to be built with people with lived and learned experience without bias built in. So it's kind of a plus and minus. So all of those things, and I mean, we have personal story after personal story of people who have experienced racism in their clinician offices, and then it results in disparities.
Barry, is this initiative aimed only at eliminating the experience of patients, or is it also concerned with removing racism from the experience of doctors, nurses, personnel in so many of your facilities as well?
Oh, it's across the board, John. The truth is that our consumers and patients cannot enjoy an anti-racist environment unless all levels of caregivers are anti-racist. And I will tell you, the literature is replete right now with the biases that are trained into our professionals. If you look at curriculum, if you look at practical training in our professional schools, they're now being admitted to have been constructed with certain biases that now come out when the professional is actually treating patients. So Deanna talked about prescribing fewer pain medications to people who are Black. We have data like that in many different specialties. So for us in our organization, training everyone, irrespective of what your professional role is, as well as working with our partners at Rutgers. Rutgers has an exquisite program, not dissimilar to ours, to become an anti-racist organization. And it will, in fact, be in its medical schools and nursing schools and professional schools to ensure that the future generations of clinicians don't have this bias in the training that they receive, so that when, in fact, they are treating patients, once they come out of the programs, we are hopeful that we will have pruned out this aspect of racism. But the structural racism, whether it's in education, you know, one of the things we've talked about, you have to look at this from a practical standpoint. It is true that the Medicaid program has as a membership a disproportionate number of Black people. So if Medicaid subscribers, members, cannot have access to specialists, what we're effectively doing is maintaining a reimbursement program that reduces access to the very physicians that people need. And so people can say, well, is that racist? And the answer is it's structured in a way to effectively be racist, because the issues around reimbursement and the like stop professionals from accepting Medicaid patients, and the patients they don't accept happen to be Black. Now, that is a structural issue. We're trying to work out how we can correct that. Again, like everything else, it's complex, but if we don't fix that, we can't claim that we have equal access, equitable access to specialists that are needed by our Black communities. So it really goes to every level of care that we participate in as a healthcare organization.
Can you talk a little? Can you talk more specifically about the different areas that Ending Racism Together addresses? You've acknowledged that it's patient care, workforce, community, system operations. How will this program execute? And pick any of these areas to explain, please. Deanna, do you want to start that?
Sure. So those are our 4 goal areas, large goal areas. And as I said, we are trying not to boil the ocean. So under our first goal, clinical care patients, we're really looking at disparities, some around diabetes, around maternal child health outcomes, around breast cancer. We're looking at technology to ensure pulse oximeters read dark skin the same as they do white skin, and some do very well and some don't. So making sure that we purchase those that read all skin tones the same. We are looking at making sure that our resident pool looks like our communities. Under workforce, making sure that we have the right training for our staff across the board, and we will have mandatory training for our entire workforce, all 44,000, to make sure that everyone understands racism and equity, and not training up front, but training throughout. Making sure that there is parity, making sure that disciplinary actions are looked at, making sure that our teams across the board, including leadership, are more diverse. In our community, making sure that we look at social determinants and that we are integrating them into the clinical care. So for instance, we can no longer give a patient who is a diabetic a medication that says take with food without also understanding, can you afford the prescription? Can you afford the food? Is there a grocery store in your neighborhood? So we will be asking every patient that walks through our door eventually about their social determinants. Are you stressed? Are you, and asking every patient, not though, we're not gonna be biased and ask some and not all, because we all have social determinants. And then the 4th area, looking at those areas, its operations, those areas that bolster all the others. So our communications and marketing. Do the images reflect our entire community? Is the language reflective? Do we have it translated in proper ways? Looking at our contracts, do they have boilerplate language that when we contract with other entities, that they're also committed to being anti-racist organizations? Our finance, so all those other areas that our supply chain, are we working with small minority women-owned vendors, which has been our anchor mission that we've been committed to for the last 5 years, but really bolstering that area, our workforce, and really ensuring that we have career ladders and hiring individuals of all ethnicities and from our local communities. So we are very unique. We are working with and talking to other healthcare systems and entities across the nation. And we are the only one that's looking at it in this comprehensive way. A lot of people stop at the workforce and traditional D&I, and maybe some touch on a small piece of the social determinants, but looking at it across the spectrum, we're really pleased to do that. And it is a big a big commitment, but we think we can't stop at just one or two areas.
Mhm. It really sounds thoughtful, authentic, creative, and in success, truly effective and transformational. Do you imagine, as time goes by, that other healthcare systems around the country will look to this work and model it?
Well, we hope so, John. As Deanna suggests, we're speaking to many. We've been solicited by a host of them. Excuse me. I actually have a couple of hours later today, I have a call with 15 CEOs from around the country
Oh, wow.
who run healthcare systems to talk about this.
Great.
I would like to emphasize one thing which may be relevant to some of our business partners who are attending today. I think each of our companies have attempted to launch effective diversity, equity, and inclusion programs within the organizations. We have, and we are making real progress. But for me, I think one of the limiting facts or one of the limiting obstacles to a fully successful DEI program is the existence of racism. If you are going to, in fact, attempt to ensure career ladders for people of color and other ethnicities, you can legislate that, you can actually try to promote it, but if the very people who are making the hiring recommendations or the people who are looking to fill vacancies effectively are looking to fill those vacancies by someone who looks like him or her, which 9 times out of 10 is a white individual, then you're not going to get the DEI result you want. And so it struck us that while we're committed to DE&I will not succeed unless you overtly and proactively root out racism. It is an absolute limiting factor to an effective DE&I outcome. And as we have merged those two ideas, I think we're already seeing progress in how you not only create career ladders, how you fill vacancies, how you do it in a thoughtful way, and where you find people who have filled vacancy after vacancy with people who look just like he or she does, which clearly is never going to support DE&I. So I think those two issues are integrally related. And if you don't root out the racism, you are in fact going to find yourself less happy with the outcome of DE&I.
And if I could just say real quick, I can't underscore that enough. I've been recruited for positions and I've joined organizations, probably because I'm Black and a woman, they can strike off 2 marks, and you sit at the table and you may not be included and it's still racist, and I leave, which means they have to rehire, they have to reacclimate someone new. And if you don't root out racism, you're back in shoes, and it's back in the same situation. And the higher you get and you have fewer African Americans or fewer women, it's singular and it's lonely, and you have to try to root out racism across the organization, or else you're going to continue a cycle.
Right, absolutely makes perfect sense. We thank you both for a really, I learned a lot in a half an hour, and I think everybody who is tuned in this morning has as well. We have questions from our crowd, and Chelsea, why don't you lead the questions?
Sure, thank you both. So Evan Delgado of the Terrell Fund asks, what place do private-public partnerships have in these efforts? How best can the philanthropic sector partner and support?
Well, thank you. And I'll say partnerships on anything like this are critically important. Whether it was our social determinant program or our anti-racism program, there are already organizations in our communities who've been fighting this for generations. And we can't begin to think that we have an answer that they haven't found. Typically, those small mission-driven organizations don't have the resources or the breadth to really address this as effectively as they would like. And so we would love to see philanthropic communities contribute resources to programs, and in particular to these mission-driven organizations at the local level. We, of course, have partnerships with other corporate entities. The corporate leaders that happen to be based in Newark have been incredibly helpful to us, and we'd like to think that we reciprocate as their organizations take on a similar journey. We talk together, we work together, and we raise the visibility of the issue. But I will say, as is typically the case, this is a team sport. This requires, quite frankly, everyone, because it affects everyone. And so the extent to which many organizations that are philanthropic, many funds and foundations have inquired of us, do you have the resources you need, or are there programs in which we can participate? And of course, we're honored by that inquiry, and we try to be responsive. But I would love to see more and more organizations who do have a mission to improve the lives of the folks in New Jersey take on a similar commitment.
Thank you. Joel Sherman of Atlantic Tomorrow's office asks, how do you handle patients who exhibit racist behavior towards staff members of color?
Deanna, do you want to, or shall I?
Oh, you go ahead.
So this is a very big issue, as you might imagine, and Joel, I appreciate you asking it. And this is what you find out when you start looking at things. Many of us were under the assumption that we had a very explicit policy. If we have a patient who exhibits, and many of them, or not many, those that do it vocally, racist behavior towards a caregiver or someone else in the hospital, that our policy effectively said, intervene with that patient, and if it's not dangerous and the patient won't change, have the patient discharged and admitted to another facility. Literally remove the patient from the environment in which he or she is receiving treatment. When we looked at the policy, we found out the policy didn't say that. We didn't have that policy. We all thought we did. And so we immediately revised the policy, educated our staffs that if there is a patient or a member of the family of a patient who exhibits and acts out in that way, assuming a transfer or discharge is not inimical to the health of the patient, meaning we stabilize the patient. If folks are not going to change the way they speak, the way they act in this regard, we can't treat those patients. And we just the other day, we had an episode reported on at our committee where a very courageous, I'm delighted to say, security guard saw that happening, intervened appropriately, brought in the people that were necessary, and the folks were in fact escorted out for the way in which they acted. And it was supportive of our mission and commitment. And by the way, those episodes where we do it appropriately and effectively are the biggest way that we reinforce the commitment. And as other colleagues looked on and saw this happening, they now understand this is a serious commitment. So it was a perfect example, unfortunately, assuming we did, that we already had this problem resolved, we didn't. And we went ahead and changed the policy, and now I think we're in a position to make sure those things, when occur, receive the response necessary.
Thank you. Marcia Atkin from the Healthcare Foundation of New Jersey asks, thank you for addressing this extremely important issue. We know that in New Jersey, African-American women die in childbirth or in the year thereafter at several times the rate of white women. In fact, New Jersey rates about 47th out of 50 states in US in maternal child outcomes. Can you talk about what Barnabas is doing to change this very difficult and terrible reality?
Sure, definitely. So I started my career in maternal child health, and so it holds a special place in my heart. And we have active work in the MCH space, and we work closely with the Maternal Child Health Consortium, number one, and we work closely with the state on this issue. We have a perinatal cooperative, number one, under Suzanne Spurnell, and we also have, we monitor women, number one. We do a lot of educating around the signs and symptoms to look for. We also, racism is a determinant in this area on underlying issues. And that is something that we aim to move forward for a lot of reasons. Allostatic load, meaning weathering, the body's constant response to fight or flight. And I think also understanding the stories that get us there. And early on, it was thought that it was due to issues of low income or behavioral issues, and that's just not it. It is both infant mortality and maternal mortality are factors of racism. And the reason we know this is because it does not happen to foreign-born women of color, and so we see it happening as a result of racism. So we are constantly looking at this. We have several programs around it. And so it is a priority for us. And maternal mortality is under one of our goals. Right now in our hospitals, we are on baseline with the 2030 goals. So we just continue to monitor it. We are following all of the standard recommendations along with New Jersey QIP.
Thank you. Karen Arthur asks, good science and good research should reflect the community it serves. What measures can be taken to get more diverse populations to participate in clinical trials when there is such a mistrust in science?
It is, of course, a challenge, and we're learning a lot about that. And I think the word is trust. It's very difficult, I think, to promote good scientific outcomes and even effective care, to say nothing of appropriate social programs, if the people in the communities don't trust those who are trying to accomplish this. And by the way, there's legitimate basis for the mistrust. I'm not suggesting at all that the mistrust is arbitrary. And so what we've tried to do over time, and I think everyone has a responsibility here, is how do you build that trust? How do you effectively utilize people in the community who are trusted to help us get a message out, whether it's about clinical trials, whether it's about vaccinations, whether it's about access to healthcare or tearing down obstacles to access. I don't think, no matter how many times some of us say, please trust us, we're going to attain that level of trustworthiness that is going to be ultimately effective. I think ambassadors to communities, be they be clergy or coaches or whatever and whoever effectively has already cultivated the trust, we need to partner with that trust in order to, in fact, address in an effective way, particularly our vulnerable communities. And in our business, in the hospital business, hospitals have prospered because physicians have transferred their trust to the hospital. They've said to patients, you need to go to a hospital and I trust this hospital. So that's how we've stayed in business. And now we have to go into communities and cultivate that trust, utilizing spokespeople and ambassadors who have already developed the trust. But this will be a critical issue in every facet of trying to improve the lives of the communities, be it scientific or social. And it tends to be a barrier, unfortunately, and we're seeing it right now. So I'm hopeful we'll make progress in that regard, but it's going to take an awful lot of work with the right folks.
So we're out of time and we didn't get to everyone's questions, but I do want to share one comment from Vate Powell, who says, I just want to say that in 30 plus years of dealing with DE&I in corporate environments, I have never seen this level of commitment and comprehensive engagement. I'm elated, inspired, and hope your example spreads.
Well, that's awfully sweet. Thank you so much. Thank you so much.
Thank you.
I look forward to coming back and reporting on progress, if that's okay, John.
Oh, that would be terrific. Thank you both, Barry and Deanna, for talking with us this morning. This is work that is ongoing for sure, and we absolutely look forward to hearing what this journey is like. It's inspirational to me, and I'm sure to many of our partners out there who aspire to an anti-racist organization and culture. So there's lots of learning. So thank you for leading the way. Thank you all as well for joining us this morning. And I hope you will join us again for our next Business Partners Roundtable event, when we will be speaking to Don Germazian of the 555 Group, who will talk about their enormous New Jersey project. You may have noticed it on Route 3. It's the American Dream Mall. I encourage everybody to go there, buy something, so that when Don shows up, we can tell him we're supporters. It's open. Anyway, that's coming up Wednesday, July 14th at 12 noon. Keep an eye out in your email for an invitation to that. Until then, stay well and take good care. Thank you again, Barry and Deanna.
Thank you.
Bye.
Take care.